Yeah, it's dark, I can see. I'm in the dark. Let me see.
Come on.
We are celebrating 21 years, and what better way to do it than to make sure that we go to communities that support us, we make sure that we give them educational information around their health. We are here as the clinic's family to do health screenings for the community around here. This is part of what we do in playing our part as a healthcare provider, ensuring that people understand what diseases they have, they understand that they have to manage the diseases, prevent them before things get worse. It's part of our 21st birthday anniversary for our clinic, which is based in Sebokeng, the Naledi Nkanyezi Hospital.
Thank you very much, Kamo. It was a very short clip. I was still enjoying myself and looking at one of our hospitals, Naledi Nkanyezi Private Hospital based in Sebokeng, in the Vaal, one of our hospitals within the Clinics Health Group. And I hope you enjoyed that one. And so welcome, colleagues, and to our weekly webinars that we've started sharing information, medical education, continuous professional development programs here on this platform, Clinics Health Group webinars. And we're excited to be hosting one of these webinars again this evening. And we just want to thank you very much for continuing to support these programs every week since we started in 2020, when we all went on lockdown. And it's exciting to know that quite a number of health professionals are interested in health education, and also to listen to quite a number of our colleagues who are involved in health education and others, medical education, others involved in pure delivery of healthcare delivery, whether in the public sector, whether specialists or general practitioners. And also we also encourage a multidisciplinary approach. We invite even speakers from other allied health disciplines. And we hope that some of you are in those fields. Please do contact us and make yourselves available. If there's some information that you want to share with us, please do not hesitate to share that information with us and to contact us. And so also remember that, as we said, these are CPD accredited webinars. So we trust that you will, when you join us, you provide us with your full details and provide your registration number with the health professional body that you are registered with, either the HPCSA or the Nursing Council, the Pharmacy Council, the Allied Health Professional Council, or the like. And we've noticed that quite a number of your colleagues keep on putting your details on the chat lines. You don't need to do that, because when you register, we get you all the information. That information is uploaded to the relevant parties for you to get your CPD points. So please don't do that. You can just use the chat line for chat box for asking questions or making comments. And we appreciate that very much when we get comments from you. And also, we also encourage colleagues to make sure that when you join in, we do not mute you, but we ask that you mute yourself and you also switch off your videos so that we enhance the reception. As we know that we are also on load shedding, and sometimes we thank you that some of you are on load shedding, as I am myself at the moment that I'm on load shedding, but we strive to continue to provide the information that is required every week. So this evening we are having a return to this platform from one of our esteemed colleagues, Professor Shisana Baloyi, who was with us not so long ago, and he shared with us a wealth of information on we spoke a lot about cloning of human bodies, and we've seen also examples of, I think the first cloned organism was to leadership. And so I'm not going to be doing a lot of too much introduction. Is a well-known colleague, a professional who is currently based at the Free State University and also the academic hospital in Bloemfontein. But it is this last month, I think, Prof, is this your last month? Or last few?
My last few days.
Last few days. You're moving from the Free State, you're moving over to Limpopo now. That's back home, eh?
Yeah, back home, yes.
Yeah, going back home to
the plant. Home for me.
Yeah, Professor Shisana Baloyi is an obstetrician and gynecologist and a specialist in fertility, and also an academic of note. He was the head of department. Now he is moving to Limpopo to join the University of Limpopo as the dean of the School of Health Sciences, so the head of the School of Health Sciences at University of the Taflop. It used to be Taflop University.
Yes, it's Taflop.
Yeah, University of Limpopo. When there was a merger between University of Limpopo, Taflop and Medusa, it became University of Limpopo, the Taflop campus. Now it is discarded. The Taflop campus is just a fully fledged University of Limpopo, also offering medical disciplines. So we're proud of you. We know that you will make us proud when you continue to make us proud at University of Limpopo. And also the students will benefit, both undergraduate and postgraduate studies will be overseeing everything now from that end. And not only obstetrics and gynecology now, but all the disciplines. And from your wealth of knowledge and experience, they're bound to experience quite a lot. And so this evening, as we're looking at 21st March, the human rights, we wanted to deal with something that pertains to human rights, but we wanted to look at particularly at medical training of medical practitioners in our universities. And so Professor Baloyi will be talking about features of highly effective training units in medical education, and I think touch a little bit on abuse of human rights in training of medical doctors and registrars, and also training of students when we discuss this matter. That's what we also hoped to cover that. and to make sure that we offer adequate professional and also sympathetic training to our trainees in the various fields, disciplines or universities where I've been trained. So welcome, Prof, and it's a pleasure to welcome you back, and we know that this may not be the last time we see you this year again. And thank you, and we welcome you once more to Clinics Health Group's weekly webinars.
Thank you very much, Dr. Villa, and thank you very much to Clinics and staff, as well as my colleagues who have logged in to participate in these webinars. Without you, there will be no webinars. The lecture I'm going to give, it was one of the lecture I gave yesterday, or chosen to be delivered. I delivered it yesterday after they said, what message can you leave us since you're living anyway? The bond will remain the same with the university. So I chose looking at the medical education and its problems, and how can we become, or can we change to create effective training units. So that's why the letterhead or the first caption instead indicate the university, and there's nothing about clinics. The slides will be controlled from your side. Can we go to the second slide? I have nothing to declare except that this is the team which made me experience the good and the bad of medical education training. Let's move to the third slide. Next slide. That is the outline of our discussion today. We'll have about 10 stations before I take off back home to Limpopo. Next slide. And the objectives of the talk is mainly to indicate or to share and understand the fundamental features of highly performing units or highly effective training units in the medical education, to identify the contributors to the poor training performance, and to look at what can be done as a solution to that, and to learn the simple interventions that can improve this academic training. Next slide. Now, I just want to remind us in the health profession about our other responsibilities, that when we look at the Sustainable Development Goals, especially Sustainable Development Goal number 3 and 4, that really concerns us very much. And the Sustainable Development Goals arises from when all the United Nations member states met in 2015, and they adopted a series of actionable plans looking at the 2030 agenda for the Sustainable Development Plan. And they shared the blueprint on what are the issues which need to be undertaken. And amongst that, there were about 17 of these sustainable plans which they came about, that this should be implemented to create a better world for us today and tomorrow. And when we look at these two goals, or the Sustainable Development Goals, goal number 3, which says we should be able to provide good health and well-being, meaning we should ensure healthy lives and promote well-being for all at all ages. And Sustainable Development Goal number 4 is a quality education to ensure that it is inclusive and it's equitable, quality one, and promoting lifelong learning opportunities for all. So these two goals are very much dependent on the medical education. Next slide, please. Before we can go on, let's look at the main keywords in our discussion, which is health and education, and define them. And the World Health Organization define health as a state of complete physical, mental, and social well-being, and not the mere absence of the disease or infirmity. And from that definition, it's a mouthful that there is a lot, not necessarily having an ailment, which means our education, if it's not well, also it may indicate that there's some problems with us. Next slide, please. Next slide. In terms of education in health, Lawrence Green defined it as a combination of learning experiences designed to facilitate the voluntary actions conducive to health. Again, in the same definition, we have these words which came together: combination, design, facilitate, and voluntary action, and which combination reports or entails the importance of matching the multiple determinants of the behavior with multiple learning experiences or educational interventions. And design, meaning distinguishes the health education from the incidental learning experiences as systematically planned activity. And facilitate means to create the favorable conditions for that action of education. And voluntary action referring to the behavioral measures which are undertaken by an individual or a group or a community to achieve the intended health effect without any force, and that is voluntary. Next. When we look at the health education or the approaches or the medium or the areas where we conduct it, it could be individual approach, which could be counseling, clinic consultations, and home counseling. It could be a group approach, which could be involving lectures, like in this case, we are busy with webinars, group or panel discussions, and same as in this case as well, in these webinars, the workshops and seminars. And the third one is the mass approach, which could be the utilization of the media, whether it is print media, electronic, and as well as this one is another form of the media communication, so radio, internet, newspaper, or printed materials. Now, why is it important to have a good training unit or have high quality training environments? It is important because with effective training units or high quality training units, you are able to develop high quality doctors or healthcare personnel for the future, especially in our times of increasing complex patients and high training attrition, because that is a problem we have. This high training attrition, which we will discuss it later on. The high performance or high quality training environment or very effective training units, they provide patient safety. They also provide patient safety training environment. It also prevents trainees leaving the profession, meaning it reduces the attrition rate, as well as it prevents burnout among the healthcare workers. Next slide, please. Now, another reason with training units which do not fulfill the effective or are not in the meeting the tick box of high quality training units, it's among the features which are prevalent, there's evidence of bullying and undermining of the junior doctors. And therefore, you are able to read what is happening in the training units with the trainers themselves through the juniors or the junior doctors or the trainees which are under their supervisors. What you read from there is that these trainees which are bullied or are experiencing bullying, they have apathy in their work, they have poor decision making, and they make many mistakes in their conduct of their daily activities. They are less likely to voice their concerns over patient safety issues, so they are not much concerned about what's happening. They were given if things are going wrong. And there's evidence of that. There's decreased productivity and lack of confidence with these trainees or students, whether it is in the registrar or postgraduate level. So it is very much important that we make sure that our training units remain high quality training units or very effective training units, because in those units which we do not have the necessary criteria, are not effective, we have a prevalence of bullying or trainees which displays characters or features of not being satisfied with their work. Next slide, please. And therefore, as I've said, high quality training environments increases job satisfaction, it reduces the attrition rate, it also will reduce the student dropout, and it will increase thorough output. It promotes excellence in education and training, and it leads also into the increased throughput, because you will have reduced the dropout rates. Now, there are 7 reasons why medical students drop out of the medical schools. First is the changes in life circumstances, moving from high school life to the new environment, tertiary, it may be stressful and all. The academic capacity, which has to do with the preparations before, especially if you're coming from the poor rural side. Some of the students, because of tuition fees, they could find themselves undergoing part-time work, and that can really disturb them. Absenteeism and the leave of absence. Absenteeism could be either with many other reasons, sickness or lack of money to go to school. And the leave of absence is the leave which you could be given by the institution, but when they come back, they've forgotten about what has been happening. They got used to the relaxation in the out of work. The false perception of their medical specialty before enrolling, that it just looked charming, but when they got in there, they found that, oh no, it's different. It's got a lot of stress. Number 6 is that there's a lack of discipline and self-organization themselves, which many of our students find themselves that they have not gone through. But the 7th part, it is their behavioral related reasons, which could be due to drug addiction, alcoholism, illegal activities which they could be engaged in, and conviction. The 7th part is very much important because a poor training units can induce that, can be the source of it. Yes, it's a paper written by Kathleen and colleagues after they have done a retrospective study or prospective study of qualitative analysis in one university, where they look at the medical students' experience of mistreatment by the clinicians and the academic at one of our institutions. What was more worrying in this finding or the study is that the student mistreatment was found to be prevalent among the medical students compared with the other medical students internationally, despite the fact that we had so many years of our democracy, more than 20 years. One could have expected that things would have changed to the better. And in that, it was that there was a high rate of racial and gender discriminations. There was issues about language and gender discrimination were very much more prevalent in this. And since the findings of this study, an anti-bullying poster campaigns has been initiated to try and deal with this problem. This was conducted in one of the institutions, which I'm not going to mention it, but it's a recent paper which was published in January. It comprised of about, if I remember, 800 eligible medical students where they were interviewed, and about 50% of them, which was about 450 or 43 something, completed the survey. Yeah, I think it was around 55%. And in that survey, 83% reported mistreatment, and the type of mistreatment was that they were being ignored, and the 75% in that mistreatment was offensive gestures, and 65% was related to verbal abuse, and 64% was discrimination, which was either gender or racial. And this was far more prevalent and very pervasive. And then later on, they had to go and look at who were the perpetrators of this. Next slide, who were involved. Next slide, please. Thank you. The person involved in this mistreatment of our students were registrars and consultants, were the most reported professionals in that, and registrars were comprised or contributed to about 60% of them, and the consultant comprised or contributed 47% of the abusing. Meanwhile, the professors and the heads of department were less likely to be endorsed as perpetrators, but in that they found that 11.3% of them were also part of that. More than half of the students reported experiencing mistreatment by other hospital staff, which included nurses, administrative clerks, and managers within the hospitals, and that comprised to about 56%. And the area which one would not have thought they are involved in that. Now, let's look at the themes which were described by the students in this mistreatment. There were three main themes which comprise of the condensations, the threats, the fear, and the third one was discrimination. So this was the main things which were concentrating on the themes of the complaints from the students, from us, the trainers. Next, please. Next slide. Thank you. Now, in conclusion of that study by Kathleen, is that the medical student mistreatment in our universities are still prevalent and had significant perceived negative effects on the student mood and academic performance. And in post-apartheid South Africa, reports of sexual and racial discriminations were particularly concerning. Therefore, to safeguard the health and well-being of students and improve the learning and patient care environment, medical schools need to be more aggressive in their efforts to prevent such incidents and provide support to those who are affected. Next slide. Now, the problem with bullying is that it results with the students, whether it is the undergraduate and postgraduate, to tend to resort to substance abuse and alcoholism, as well as other drugs. Next slide, please. The other problem of bullying is that it contributes to the high attrition rates in our training centers, especially in the medical fraternity. This was an audit or conducted by the Royal College, and found that the attrition rate, especially in the obstetrics and gynecology, was high, comprising about 30%. And it was the highest amongst all disciplines or specialties. And the reasons for this attrition included the low morale and trainees who were exposed to undermining or bullying, the training processes, which were very tortuous and sometimes lacking support, and a lot of paperwork. There was lack of support and supervision was the issue which contributed to high attrition. The work-life balance, where there was a lack of social interactions at work, and even there's a lack of community feeling of brotherhood. In our case of the training in medical, especially in obstetrics, that we're training both doing service delivery and academics, the platforms where we are training are overstretched due to understaffing. So the registrars or the students themselves, they feel overworked. There was the issue of job satisfaction, where the complaints relate to inadequately remunerated and inadequate vacation leaves, where the leaves are kept or timed that you can only take leaves up to so far. And one which was topping was the unsupportive learning environments, especially for their intentions, which they came for academic, the skills and research. And they found that no, it's better they leave. So high attrition rates affect the remaining workforce and can have a negative impact on the working environment and contributing negatively to the patient care. So it's very much important that our training centers are effective or of high quality. The contributors to the high attrition rate or the poor training performance were perceived job stressors, and the additional factors have been found to play a role in this workplace bullying in the hospital environment was the lack of resources, where in our training platform, sometimes we have to improvise on the material or equipment we are given. Instead of having a quality ultrasound, then you have such a machine there, which you don't know whether it is a machine which when you use it, it's gonna explode right there or not. And the high patient loads, which we are understaffing, as I've already mentioned, and the issue of the language and racial discrimination, which came out through that paper by Kathleen. Excessive working hours, which are associated with a lot of burnout amongst the healthcare workers. And this creates that the healthcare workers or the trainees may not perform well and be more likely to leave the profession because they are not enjoying. Next slide, please. So now the issue is, what is the solution? What must be done to have a balance? Let's look at that. How can we tackle these problems and have solutions? Thank you. My first is that there was an investigation on the risk factors for the academic difficulties in the medical program in South Africa. And this was conducted by Sifiso and Judith, where they found that a total of, it was also a qualitative analysis, total of 475 students experienced academic difficulties, and about 16% experienced the same difficulties in their first year of studies, and about 14% in their second year, and about 5% in their third year. And these results show that the intermediate, upper and lower and basic levels for all the national benchmark test domains, whether it is those who are living in the university residence, coming from the rural areas or the poor affected background, male genders were more of those who had more difficulties or affected. The conclusion was that in mitigating these factors, the national benchmarking test must inform the type of support programs to augment the students' skills and promote academic successes. And this has started in some of the universities where they track they're able to pick up the graduates, or not the graduates, but the students who are at risk of dropping out and also experiencing social challenges, and then they are afforded social support, whether it is because of their financial background, lack of finance, accommodation, and even their background of their schools. And these additional existing support programs should be also be evaluated to ascertain if they reach the student at risk, and whether they're participating in these programs, do they yield the positive results and academic outcome, which we are looking for. Next. So, Professor Kishasa and Kisansa and Lubinga also conducted the qualitative analysis looking at the strategic and focused solutions to the challenges which are faced by the medical postgraduate students, especially on the research side in performing the research. And they found that part of the reasons for poor research performance and the issue that there was reduced thorough output because they will be lacking with their research component for their MED registration required for their HPCSA qualification. They found that the prior research exposure and attendance of a research course were important factors in influencing the postgraduate students' participation in the research and even making them able to do their research and complete. So the institutions are encouraged that they should strive to improve supervisory and mentoring support, as well as to provide biostatistics support exposure to these students. And there's a need to reinforce the time, especially for research activities, in order to counter this decreased output. And that is one of the areas which we have indicated as the contributors to poor performance, that there's no time frame or there's not time available to the students, both undergraduate and postgraduates, to be able to do some of the necessary things. So the medical learning environment is another complex issue in our medical education, because there's a competition between the service delivery as well as the academic. It's so multidimensional construct. There is a constant potential for conflict between our bosses or our masters, the service delivery component, and the academic part from the university. That the trainees feel that there's high intensity training opportunities, such as in elective gynecological theater, but there's a problem that there's too much work and too much patience. The duties that they feel, or the trainees, they feel that their duties, they have to focus on a day-to-day patient care, because the primary bosses, which is the government, or wants also the service delivery to take place, such as the ward cover and including the calls or after hours. The administrative tasks which the trainees, both undergraduate and postgraduates, are faced with. You have to fill in the forms and death forms and all those things, statistics, they feel overwhelmed on that service. And the distinction is always blurred, the distinction of the service delivery and academic, because that is where the academics happen. So it has to be also catered. So as often, all activities have both the training and the learning benefit. But however, it is the mix of activities and the ability to learn and develop skills that is very much important. So we have to satisfy both of them. So the Royal College conducted the survey in 2017 to look at the attrition. And it demonstrated that 75% of the ONG trainees had seriously considered leaving the specialty, with about 89% feeling low in mood, depressed or anxious, and 90% stating that they felt this way at least on a monthly basis. There was also high-profile cases surrounding the trainee involvement in adverse medical incidents, which led to more trainees questioning their choices that they've come to the right place or not, with some considering such cases to be a step backwards for patient safety and the blame-free environment. Next slide, please. So now, how do we move in trying to address these problems, reducing the attrition rate, making sure that our trainees, the students and the postgraduate trainees are satisfied and we reduce the attrition rate? So in looking towards a holistic approach in the medical education to reduce this, the Royal College Training Evaluation Committee compounded or drafted the document which it suggests that if we look at, we can be able to reduce these problems. So traditionally, the focus has been on identifying areas of bad practice where improvement is needed. So that's where we said you as a trainee, you have done wrong here and there and there. Now, in the current approach that in the clinical arena, there has been a shift or a change of the focus from the learning by reviewing the negative events and outcomes to the learning from experience and from excellence. So the positive reinforcement of the positive good results. So positive reporting strategies have been shown to improve a positive working culture, which in itself has been associated with improved patient outcomes. The same use of positive reporting and learning from units which were assessed or deemed to be excellent performance may have been or has shown to be beneficial in the medical education and training. So in 2017, the Royal College Training Evaluation Committee shifted the focus to the lesson that can be learned from the highly performing units, asking the educators at these units to provide feedback and insight into how they have created the effective learning environment, meaning how they've achieved excellence. It was considered important to reward the excellence in these units. That was the most important thing, as well as looking at the positive reporting strategies to investigate the ways in which they provided this high quality training. So next slide, and then we look at what they came up with. So one of the areas where we need to look at is that the factors that may reduce the trainee attrition is when the trainees feel they're very valued, as individuals, the flexibility and predictability, the standardization and transparency in the process to promote fairness in the whole, the access to quality support, and the learning focus training. So whilst the service delivery point is taking place, let it also be enhancing the training part of the training. And this, reducing the attrition in units and retaining a well-functioning workforce may improve the training and the environment. Now, these pictures which you see there, it's a part of trying which we were implementing in the department of showing value to each individual who participated or contributed towards the good success of the department. So as you can see so the lessons from the top 10 performing units or the high impact actions to improve working conditions for the junior doctors, which was derived from the RCOG survey, was that promoting the rest breaks and safe travels to home the improved access to food and drink. So wherever they are, the training facilities, they should have access, good access, ablution facility, place to sleep, and have the place where they can be able to make drinks or coffee for refreshments. To reward the excellence, positive reinforcement, better engagement between trainees and the board, which is the hospital management as well as their trainers. The well-being support and mentoring, the rotas or the co-rosters, which they have to be involved in terms of drafting it so that it can even balance the work and life. The leaves should be taken care of, and sometimes there's other social lives which they need to take care of. Creating clearer communication between trainees and management, and tackling the work pressures has been shown that this has improved or reduced the attrition rates in the NHS or Royal College survey. Next slide, please. Now, when we look at the traditional way of the platforms of education, it had three themes, which these three themes also, they are, as you have heard when I read that, they were also dominant in their approach to finding the solutions or to this reducing the attrition rate or making them feel at home or enjoying the training as well as while they're conducting service delivery. So a sense of community, meaning that the training environment, the trainers, the trainees should not feel lost when they're at work. They should feel that they are part of a community. So the trainees need to feel they are part of a community where education is a priority and which offers a sense of belonging and the striving for the cohesion and community, communeness or oneness, where they are committing their time and efforts to achieving this one goal. And this goes beyond the issue of the team working, but a working community with a joint ownership over the things which happen there, that when things go wrong, it is not the trainee's problem, it is our problem. When things go well, it's ours. As well as fellowshipping and well-being, the safety, the trust, and it must be paramount among the trainees as well with the trainers. The other dimension is the collegiality, which should be more than the corporate belonging. That the collegiality should not only because we're just working together, but there may be issues where, in terms of management, you're discussing the approaches. In that case, there may not be the right or wrong answer, but as professionals, they should exercise their own judgment based on their practical wisdom and practical reasoning, thereby becoming reflective practitioners. That the trainees should also be given the time to discuss these clinical situations without feeling interrogated, but with the guided questions from their leaders or consultants to advance their thinking. So the trainees should take the advantage of consultants' wisdom in that they are their guidance. And the commitment to criticality, it's in terms of when things go wrong, in terms of critical appraisal or critical assessment, so that everyone who is there should be free to participate and contribute well to the effect of the training and what has happened so that everyone can learn. Next. So these dimensions have become part of the even the latest RCOG answers or suggestions to improve training units to be of high quality. Actual fact, I was talking about this slide is what I've been trying to explain in that. I think you can move to the next slide, please. Thank you. Now, if we want our training units to be the best as described by the survey of the Royal College, what are the checklists or the quality criteria that the training units can use to benchmark their education and training against them? And this came out from the same survey of the 2017 Royal College to try and improve the situation and reduce the attrition and frustrations of which are experienced by the trainees as well as the students. In that a bench or the checklist criteria, they had three domains. The first domain is the one of ensuring the safe and effective care. And in that domain, it comprised of the multi-professional team working, the handover of patient care that it should happen as guided with the consultant, and in that handover that there should be knowledge or skills imparted to them. There should be benefit from both sides. The one who is coming in and the one who's going should have benefit from the previous call and learning from them. The consultant contact who should be there to assist and help with queries and in terms of the management of patients. The clinics should be well run, which are very much essential in terms of the transfer or they are very much in the clinics which are involved in assessing the patients which are creating a heavy load. They should be well run, that they are able to pick up, trial the patients and refer them early. So there should be a very good connection between the referring hospitals and the smaller hospitals. The clinics should be running well. And the responsibilities for performing clinical procedures should be guided where there must be a backup in terms of the consultants and the trainers. Next slide, please. The domain number 2 was the creating a supportive environment in which multi-professional team working was still part of it. And the induction of the new trainees, inducting them in terms of the protocols, knowing where things are found, the support and all this. And one of the other issues is the valuing trainees, which I have mentioned, that their participation and their contribution should be valued, even if there are problems which happen there, that when there are problems, they should have collegiality in addressing them. Maximizing the effectiveness of the trainees by skilling them, making sure that the trainers are available to support them, and the working environment is supportive, having all the necessary equipment or the tools which they need to effect or conduct the service delivery for in a quality standard. And the college tutors to be available to assist and supervise them. Next slide, please. The other was the core roster design, and should be in conjunction with the trainees and the management, and the trainees to have a representation which can relay their frustrations as well as their happiness, or if they need to make any contributions to that. The infrastructure was a very critical, as I've mentioned, that the infrastructure which should at least provide the basic things where they have if they are on call, they have a place to have a rest, be able to have ablution facilities where they're able to refresh themselves, to have the facility where they are able to make a tea or coffee to refresh. And they should be also, again, supportive doctors in the training. So there should be availability of consultants even throughout 24 hours, even during their calls, who they can be able to consult them to verify their plans of patient care. Returning to work when they are from, especially the vacation and leaves, they should get some form of debriefing in terms of what happened in their units and handovers and all this. The opportunity to work less than full-time, flexibilities in the time when they are preparing for their examinations and as when they are trying to complete or to attend their research, so to have that reinforced time. The support following serious clinical incidents or poor outcomes. This is the debriefing which should be in place in our settings, especially the medical training, that when the morbidities and mortalities take place, it sometimes breaks them. They can break their morale. We need to set up these different debriefing facilities where some of them, they might even need further counseling, so that support is very much important there. So when things go wrong, so that it doesn't look like it was an intentional. Most of the time it is not intentional. It just happened that way. The multidisciplinary team, procedures training, where the skills transfer is important. They named educational supervisors, so they should know who are their supervisor who will be conducting their assessment, their work-based assessment and follow-ups. And the provision of feedback whenever they are doing, if they're doing well, that's it. If they say something wrong, you need to have a collegial approach to that. The leadership or management styles in the clinical environment is very much critical. The support for educational supervisors, so meaning that the consultants, they should also be given the support for further training, to attend workshops, congresses where they can upgrade their knowledge and come back with skills so that they are very good educators and trainers, has been one of the important domains. Now, what are the hallmarks of highly effective training units in medicine? The hallmarks of highly quality training environment or units, they have increased job satisfaction, there's reduced attrition, they promote excellence in education and training. And what have we done to deserve this attention that we give these types of lectures? Because this was a lecture I had to give at the university, and this is because in that 6 years of leadership where I was or where I'm still at the Free State, we had about a thorough output of 31 MNs with 100% pass rate for the 12 exams which they've said or were written in my presence. And in that 6 years, there were 3 subspecialists trained in reproductive medicine and endocrinology with 2 PhDs output. 27 of these candidates were the direct trained and project supervisions, which were undertaken by ourselves. And the most senior by then was about 12 months in the training. In terms of the race colors, there were about 5 which were whites, 3 male and 2 female, and 25 of them were Black Africans. Now, that was a question that
do you believe in
hallmarks of a highly effective training unit is both academic output and body of quality healthcare delivery. And with so a reduction in maternal death by about 50%. So that is how we end our story. That if you create high quality effective training units, you end up with good academic output and good quality patient care. So during my stay there, the number of trainees that left the department was 7. 4 were because they were stagnant in their milestones with very high maternal morbidities. 1 was a transfer to another institution who is now qualified as a specialist. 1 left because of social reasons as she was getting married to another place. And 1 was an elderly who was stagnant and the milestones were not improving. So that was the results of my stay there. The next question is, what type of leadership style was applied during this 6-year stay of my leadership? It was mixed, autocratic and democratic. But autocratic really is a very dangerous one, because once you apply that, you must be sure that whatever you are putting through, it has got, or it's going to yield positive results, which means you must know that road which you say, we are taking this road. So it means you have traveled that road. You are not traveling that road once. So what did we do? We had our curriculum drawn, an annual program for the individual personnel of the unit. We had periodic assessment, OSCE tests, or examination practices with academic, clinical, and individual focused mentoring and assessment. So what we did, we inspected what we expected, what we expect from our trainees, both the undergraduate and postgraduate, is that they should excel in academic and patient care. That is the wish. So, but we went through and make sure that it is really happening. So the research supervision was that from day 1 of the appointment of a registrar, they were given projects and which was followed up periodically every quarterly. Social cohesion, we created a community where every Fridays we have our M&M meetings. So in those Fridays, we use them to celebrate the birthdays of everyone. So if you had a birthday in that month and that week, we will celebrate your birthday on that Friday where we buy food and then we are together there. We had dinners when we have external examiners, special lecturers, and visiting professors to entertain, to make sure that we create that cohesive community. The trainees were sent for training in other institutions where we were weak. The trainees included our fellows, our junior, where we'll organize training facilities for them to undergo that. And we involved the community also, that we had several community education forums, outreach, and M&M, which included the primary healthcare workers being part of us and the community. We also imparted skills to the low-level skills, healthcare workers, the ward-based outreach teams, and that improved the situations. Next slide, please. In summary, the attrition rates among the trainees, both undergraduates and postgraduates, currently is very high. And this is concerning for the future of the workforce and the women's health in our country. A good learning environment not only reduces attrition, but it improves patient safety. Many of the factors that increase attrition will also have an impact on the training and education. And therefore, initiatives to tackle one of these problems, which has an impact on our training or quality, is likely to help or have an impact on the other. So units suffering from high attrition rates are also likely to struggle to provide effective training to the remaining workforce due to the need to cover the on-call rota of the missing or the staff which have left, and the activities will be or the one which we consider as service provision will suffer. So highly effective training units in medicine are the critical facets for our quality healthcare delivery in the country. And this is the A team which was involved in a highly effective, or what can be perceived as a highly effective training unit of the obstetrics and gynecology, where I was at the helm as a leader, as witnessed by the note of the patient there, which I've shown you there. That is the note which was written on the 17th of January 2023 of a patient who was satisfied. I thank you, Kanimamba. Thank you all just for being here for me again. Bye-bye, I'm gone, no questions. Thank you. I hope I'm still on the air.
Yeah, you're still on the air, flying solidly. Well, you're still floating.
Okay.
Yeah, even though I see the plane has got lots of good luggage on top of the plane instead of inside the plane, but it is still on course and it's still floating, and it's on its way to Limpopo. I can see that. Thank you very much, Prof. It's quite an exciting and informative discussion on training units in our country. And I think I didn't know that there were so many studies. I mean, I only came across the study that you mentioned, the one in Stellenbosch. So I mentioned it, it's out there. It was there in your document. The one, the training that we, I blurted it out.
Well,
okay.
I didn't want to mention the institution.
well, they published the paper. I had a chat with the authors of the papers, trying to get them also to be part of the webinar to do the presentation. Unfortunately, the main author is currently away and unable to join us this evening to share their insights on the outcome of that research. They didn't say it's published, so it's public, so we can have access to it. Yeah. Thank you very much. Well, I will go to the questions, but you are well known for your solitary demonstration at one of the graduations of the Council for the College of Colleges of Medicine in South Africa. And I see that I'm not sure if it tactfully avoided talking about the training, because I think when you speak about training, you only looked at training at in the clinical setting at either the university or in the hospital. But there's also training that is coupled with the qualification of or endorsement of the training with the Colleges of Medicine of South Africa. And there has been an issue of a high failure rate, or maybe it's not high failure. Perhaps I could say that, I could be incorrect. But there have been issues about the number of unsuccessful candidates writing the Colleges of Medicine exams from different disciplines. There was an uproar about 2-3 years, I think 2019, when there was a division. Some universities, they all failed, I think, in the surgical discipline, and other universities, it was clear. What's your comment about the involvement of the Colleges of Medicine of South Africa well, I think it's about qualification, because they're not training per se, but they are doing the examination of students, of candidates. Right. Yeah, maybe just let's put this to bed, and just your views about that.
Yeah. Well, there's a speech I delivered. It was titled "Transformation: The Future in the Health Education of South Africa." This was I addressed to the South African Medical Association, SAMA, gala dinner on the 14th of April 2018, right here in Bloemfontein. It was on the day when I came back from the funeral of our stalwart, late Mama Mandela. But in that, I had put some way forward because we are not satisfied, even currently, these issues there in the colleges of medicine. So I hope this time we'll be able to sit around and make sure that there's standardizations in all these colleges, because yet there are colleges which are trying their best to try and look at the issues of where we come from, where we are going, what do we want. But in that address, I had said, I'd given some suggestions to move forward, that the unions or the representatives of the trainees, which is in our case is SARA, it should encourage the discipline and hard work by registrars, which sometimes was there. It's the issue of this the RWOPs fight, which is with the trainers and the trainees. And we should also get the privates to be involved, because they are tapping in. We are training, and then the registrars who are consultants, they are going to the private. They are not part of it. So we need to move that the private must be part of that. But let's go to the college, and let me leave the others. Let's go straight to the issue now. That the colleges or the colleges of medicine should make sure that all the universities should be really represented in all the college examiners. It is happening, it is going on now, but I don't think there is 50-50 representation, including even the gender issue. Now, the examiners should be allowed to examine the candidates from the other sides, not examining your own candidates only, and at the end, the automatic passes there. And there should be an ombudsman, because currently the complaints are not handled impartial, because you are complaining to a college and the complaint lands into the president of the college. So there's no one to make sure that there's impartiality to handle your problems. I will stay away from how the colleges of medicine got involved in the assessment, because that's a big issue now between the Department of Higher Education and Training and the Health Professions Council. So the Health Professions Council also, it has neglected its own functions there. So, which we will need to iron it out. Lastly to that, it's the issue that why the training institutions have suddenly been excluded to be the ones no longer assessing the students which they've trained. Because if you look at the documents of the Department of Higher Education, there's no way where it indicates that the training institution should be outsourcing another body to conduct the examination training. So somewhere there's a problem which we need to sort it out. And that brings us to the fact that the MED should come back, and people must have a choice. They should have a choice. I mean, it's the same as you have a choice to become a lawyer, either you study from University of Limpopo, University of Banda, or University of Pretoria and all this. And that's what it used to happen. What we need is to make sure that we put quality assurance system, because the colleges of medicine has got its own problems currently, as I've highlighted, that although the examiners there are purported to be the trainers, not in all the colleges. If things were hunky-dory and going smooth, we will not be having the problems we have. I'm sitting right here with a number of complaints. The complaints are still there. And before we can get the reparations of the people who have been dealt very badly by the colleges in the past, I don't think we will move well. So there are a lot of issues in the colleges, and I hope the committee of deans will engage on this seriously, not a tick box, serious engagement and looking at our statutes as to what. Yes, so it's a serious problem, which I don't think we will be able to get it out. Now, yeah, but I note it, and I know it, and I have gone through as a trainer. I've seen it, and there is a number of complaints which are there. So, yeah.
No, thanks a lot. I just took you off course there with that question.
Yeah.
I think Modern Pico wants to know if we're recording the sessions. Yes, we are. Don't worry, these sessions are recorded live on YouTube. So if you want to access them later at a later stage, you may be able to do so. As soon as we end the session, that this recording will be available on YouTube. I will go backwards with my questions, just to cover the questions that were not in your presentation. And Dim Kari wants to know the 2-year training for internship, the 2-year internship training, and another year for community service. The question is, does this help in improving the quality of newly qualified doctors, or it is just a delay or discouraging doctors from pursuing specialist training? Your opinion on this?
Well, my opinion, it is a very good initiative, because the problem we are having with the current students is they are not the same as we were. They have money. During holidays, we used to spend our time doing practicals, being taught how to suture, how to reduce, By the time you complete your 6th year, you are a real overall general practitioner who understands it. Unfortunately, I have to state it now because I'm a trainer and I've observed the quality of doctors we are producing now. When they pass their final year, are no longer that quality, because they don't spend much time in the training. They have a lot of time. They are doing all this mountain climbing and all this. So that 3 years, the internship, and 2 years, it is very critical, important to make sure that. Remember why it is we are talking about training people who are going to take care of the lives, our lives. They must know what they are doing. We're not. They must really know what they're doing. But currently, I see them. When on a vacation, when they come back, you start afresh. They're forgotten, because wherever they've been, they've not been in touch with. They were on holidays. And the healthcare services is a continuous thing. Once you stay away from it for some time, you forget. You may even forget the simplest things which you were able to do. So that it does nothing to reduce their time. It's very important. It's quality time, because it covers their time. If they want to be, we may change the training where during the holidays, now they must go and spend time in clinical, which is what we used to do. We used to go and do our clinical works and all. But nowadays, on holidays, they are at some mountain climbing there in Cape Town and somewhere else. When they come back, they're forgotten. So that's important. Yeah. That is from the word of a trainer. Yes.
Yeah, no, thanks. When we're training, we used to do that as part of our extramural activities in that 6 years or so. Mountain climbing and so on. It does, we used to have those social clubs that would do that over the weekends. But it's part and parcel of the training. There's a question here from Toko Khongwana. Prof, thank you for the insightful, detailed presentation. Your view is the community, collegiality, and teamwork themes. These 3 things, are they related to the principles of the interprofessional education and practice, IPECP, which has been introduced in most medical training institutions globally, including some institutions in South Africa? Are these themes related to this IPC
Well, they are related, but it has been an old tradition which was practiced. That's why we say in an institution, including its research, the research it conducts, it must also have an impact on the community, as well as the community must have the say. If you look at how we're trained and how we're doing our activities at Medusa, it was precisely like that. The community was not left behind. What was happening at the university was not, we used to go out, visit the community, deliver primary health care. So we knew what is happening, the interaction there. So that is part of this. So it's an important, critical, important element to the training, the quality training we have, and as well as the quality existence for the institution, that it adds value in that way. So that three sphere is very much important in creating a good quality impact in our life.
Okay, there's a question here, but we're going global now. Frida van Antwerpen. He wants to know, makes a statement initially. Medical students with ethical concerns face great difficulty to refuse or challenge their trainers, one, and reporting fear of retaliation, and this can be subtle. An example that in the US, in evaluation scores, in the US, it was common practice for medical students to study the pelvic exam on anesthetized patients without obtaining prior informed consent from them, and also that similarly, insertion of the CVP lines was practiced on the just deceased patients, oftentimes without consent from the family or deceased patient prior to death. Some states have thought about a reform, although it sometimes involves a vague small print. So I'm trying to read small print, consent on admission, which the patient does not notice, although overt racial abuse may be reportedly higher in our training environment. The fear to challenge superiors might remain universal. So I think it's a question about, students.
Yeah, there's mixed issues there. The writer is talking about the students' fear to report any grievous, and there's issue about that the trainers will be performing certain procedures on corpses without the consent and all this. But from the student point, that's why we're saying one of the recommendations in one of the papers I've said, especially with the one of Kathleen, is to make sure that each and every training institution should have the forum, should have the facility where students are not afraid, whether it is undergraduate or postgraduate, that if they are aggrieved, they are able to approach and say, I have a problem here. It looks like I'm getting an attitude from my teacher, and whatever, whether it is racial or gender discrimination or I mean, like in our case, I went for a training at the University of Pretoria and for my postgraduate, and then we just decided to start speaking Afrikaans on the. But meanwhile, and there's another person who was unfortunate, hasn't even touched Afrikaans from Africa. We were training with years, and then now I will be the only one who will sometimes catch there and there, and you understand. So, and if you don't have a place where you're going to complain about that, then it becomes a problem, isn't it? That you think if you complain about, and that's where we ended up. Our former justice had to give out about the issue of the Africans versus English as in the media of language of media instruction, and we said this Afrikaans was creating a barrier. So institutions are encouraged to create the facilities, whether it is where students or trainees can be free to go in and report. The ethics of the autopsy is something different, because sometimes the disease could have given that consent and said, when I die, I want it to be donated to as a cadaver. And so the work of being a cadaver will start immediately when somebody has confirmed that there's no longer a heartbeat and all this.
Yeah.
But if the institution has the facilities, that can be reported. Yes. Thank you.
Thanks. Yeah, I mean, there's a similar question. I think 2 comments from Mohammed Farouk. I think you've covered that part about students being encouraged to complain, and that there should be a vehicle for complaining.
Yes.
And
Yes.
what you said that to me, because basically the students or even other healthcare workers should be advocates for patients.
Yeah.
I think we've covered that. There are last 2 questions that before I will end with a contentious one last. But there is one question. Someone says, these studies that have been done in South Africa, we've mentioned studies in Stellenbosch. There's a study in the US of Pretoria. There could be other studies elsewhere in the country. You mentioned studies in the US about attitudes or relationships between trainers and the students. Shouldn't we be doing the same study in Cuba, where it looks like there are similar issues? I think this person must have insight. But I'm sure when you speak to, there have been issues. I mean, we've seen issues being reported in the media about the way South African students perceived their treatment by their Cuban trainers. So should we maybe sponsor such a study in Cuba?
Yeah, well, there is even, I don't know whether it's a preliminary report, because our government has decided to change the approach in terms of the Cuban training, where I think there are 2 institutions which have already bought into that. It's Walter Sisulu and I think University of Pretoria, if I'm correct. Yeah, that the Cuban arrangement now will happen inside the country, either by bringing in the Cuban doctors to be able to deliver or teach the primary health care, which they are very much strong there indeed. But precisely it arises from the complaints of the questions which are raising now, that they say it looks like there's a problem. And one of the problems there in Cuba was created by our own students, because they were earning more than even their teachers there. So, and some of them had just decided to become so much unruly and all this. And so it was a two-way. Yeah. There was that problem. Meanwhile, that created a negative attitudes from both sides, and the teachers, the trainers, the tutors, they said that this South Africans have got an attitude, and all. So they came with an attitude. So that was another problem. Yeah. So I don't know if what informed the decision, but definitely there must be evidence base of such things happening. It was not yet a formalized one. I haven't found yes. Yeah.
Okay. I'm sure someone in the HPCSA or government budget of health, they will deal with this and we will give comments about this. And they, as you said, the committee of deans, because they are part of the training generally in the training of medical students, South African medical students in Cuba. The last one, I'm sure you must have dealt with it quite a lot. The Cohen method. I don't know if it is still being, one of our colleagues has been quite vocal about it in our doctor community groups. The Cohen method that is being used for assessing students, I think medical students, not I think it's in medicine, FCP, MCQ questions, MCQs.
Yeah. Wherever it is being used, that Cohen method, I can tell you it is not it's not tested. It's not scientific. That's what I can put a summary to that. And it's one of the problems we have, that we don't have we need to have standardization in our assessment. For instance, my College of Obstetrics and Gynecology, we don't have such a thing, that Cohen thing. So if Cohen method is a good method, why should it be selective in certain colleges? And obviously, the one who's using it is ulterior. You can even say it's an ulterior motive or something. And it is not robust. It's not a robust method, I can tell you. That I can tell you. It's not something which we are supposed to be using. We should throw that thing out of the wind and use something better, because there's so many issues about that Cohen method. That is one of the issues we're talking about when we say the colleges of medicine has got problems or issues, right? It is just that when you start with the college, it makes me too much angry, because there are many people who have been relegated and made to be dunderheads because of the things which have been happening in the colleges of medicine, in the various colleges, you understand? There are certain colleges which they are doing the right things and all this. And part of it is this Cohen story or this Cohen method.
Yeah, thank you very much. Yeah. Well, there's still a lot to be spoken about, but I think you've put your views clear about the Cohen method. I'm going to take a risk, and I've been trying to communicate with Professor Solirata Imane, who's been one of the regulars on these webinars. Just to give a closing remarks, he has been involved with the training himself in many aspects, and also in the registration or regulation of trainers. So I'm going to ask Prof Soli just to give, after listening to this talk, just to do the closing remarks. If it's okay with you, Professor Solirata Imane.
Yes, thank you, Dr. Bila. I hope you can hear me.
No, can you loud and clear?
Yeah, I just want to thank Professor Shisana, because he brought up a lot of interesting issues. And I think because of the limitation of time, these issues are bound to overlap. One really is the toxicity of the environment under which we study, undergraduate and postgraduate. So he's brought up elements of that and indicated that some of those issues might lead to burnout. And of course, he made some recommendations about dealing with burnout, but this actually means we have to refocus and look intensively at the training environment, undergraduate and postgraduate. Secondly, I think he has also outlined the assessment procedures, at the college, universities, and so on, and the need for standardization. And I want to believe that the HPCSA and the CMSA have been looking at the issues of standardization. There must be some kind of collaboration and some kind of agreement as to what really would serve this country best. There has been going forward and backwards around the issue of whether the college should be the only institution that offers the exit examination. Recently, there had been also a strong move to bring back the MMed. But of course, people who were against that process were saying, is there standardization? Maybe we need a different forum where we can have different stakeholders to discuss the issues of standardization, but this is a key issue. Same examiners at the college, same examiners at the universities, but the training is primarily done by universities and not the college. There are some difficulties there philosophically. So that has to be revisited. But I think in terms of the organization of our training programs, Prof Shisana is on point that all the academic institutions should be organized, should be well staffed, and there must be openness so that students can be able to express their views, and also so that the lecturers can also express their views in terms of the interaction with students. Overall, I think we should thank Prof Shisana for handling a very complex subject and giving us many examples from the studies that have been done clearly it's not enough. We need to reinvestigate these issues. There are still students who are complaining, who are not happy, not just with the college, but with the university themselves. The attitude of examiners, the attitude of teachers, the attitude of registrars was undergraduate students, those things have to be examined. College of Medicine South Africa offers some guidelines on how to deal with these issues, but I don't think all the universities are taking note of what is in the website of the College of Medicine of South Africa. But having said that, even the universities, our medical schools, in the website, they also give guidance on how we deal with these things. The issue is, how do you really deal with complaints from students? How do you deal with complaints from other lecturers? All in all, I think South Africa is training very well. I don't want to go into the Cuban situation that needs a real full webinar, but thank you very much, Professor Shisana, for a well thought out lecture, and hopefully we'll be engaging with you when you're at University of Limpopo. Thank you very much.
Thanks a lot, Prof. Soliratam, and thanks to you for also being part of this webinars and supporting us and encouraging us. Colleagues, thank you very much. It's almost left to me to say thanks to all the participants who've been joining us every week, and we hope to see you again next week when we continue with the next webinar that has been planned. We're having Professor Shabir Musa next week will be speaking to us. And I just want to thank even those the team behind the scenes, Gambo Usakwe, who's been with me this whole throughout this year for marketing, and the team for marketing that is helping us to put together these webinars. And thanks once more, Prof. Shisana. We'll be in touch. Thank you. Have a good evening.
Bye-bye. Thanks.
Thank you. Bye.
Bye.
Bye-bye.